Okay, so firstly, a very warm welcome to ENT Top Tips, featuring as part of the PCS podcast series. My name is Dr. Alice Baldwin, and I'm one of two ENT cases peer reviewers. I work alongside Dr. Nabil Makmahi and Professor Ray, receiving your referrals. Today is the first episode in a potential series of ENT Top Tips, focusing on commonly encountered and sometimes confounding ENT issues. We're going to get the ball rolling with an ENT firm favourite topic of tinnitus. This is a frequently encountered and often debilitating phenomenon that is inherently incurable, making it very complex to manage. We will all more than likely experience an episode of transient tinnitus in our lifetimes, most notably after loud music or such like, but for some of us, the noise is constant and has far-reaching ramifications, impacting sleep, daily function, ability to work, and ultimately mental health. Today, we will hopefully provide some pearls of wisdom to assist with the tinnitus journey, inclusive of when and what to scan, how to help with optimization and management of tinnitus, notwithstanding some additional strategies to guide both you and your patient towards better habituation to their symptoms. So, first off, what exactly is tinnitus? Tinnitus is defined as a sensation or perception of sound in the absence of external stimulus, i.e., a sound in your head that's not noted or audible to anyone else around you. Intensity and sound experience will vary from person to person, but can range from low-pitched buzz to a high-pitched whistle, from whirring to pulsation, and even extends as far as music or singing, something which we'll come to later with our resident expert, Professor Ray. Patients will frequently report that symptoms are affecting their sleep and can peak or become more pronounced in states of heightened emotion, such as stress and anxiety. The more fatigued they become, the more intrusive the tinnitus, the more sleep is affected, the more intrusive and overwhelming tinnitus, and so the spiral continues. So sleep is super important to stabilize. As of today, there is no known cause or trigger for tinnitus, to a point where we're still unsure if the phenomenon does arise from the ear itself, or whether in fact it's more related to sound perception, auditory processing, environmental noise exposure, or even potentially more central causes. Key to understanding and rationalizing tinnitus to patients is that ultimately the ear is a super sound filter, so we'll often focus on sounds it's wanting to hear in the presence of tinnitus. This could be much more challenging, and in essence, the overwhelming stimulation results in tinnitus taking over normal hearing. Silence is no longer a friend. One of my favourite fascinating factoids about tinnitus theorises that newborns often suffer with tinnitus, hence the classic line from new parents, discovering that their babes often settle better in loud environments rather than quiet. In utero, the babe has had background noise of maternal heartbeat, sound perception of the outside world transabdominally, sound in fluid rather than in air, hence the overwhelming sound of silence once in the outside world, and how and why lots of littlies enjoy the dulcet frequencies of white noise generators or collateral background noise. But back to topic. It gives me the greatest pleasure to introduce our resident ENT cases expert, consultant otologist, expert in complex inner ear conditions, inclusive of tinnitus, hearing imbalance, former High Sheriff of Sheffield, Professor Ray. Welcome.
Thank you, Alice.
Thank you so much for taking the time out of your schedule to record today's episode. Very much a pleasure to have you join us for our debut pod. It's very exciting to be doing a pod, my flashing headset inclusive, but you won't be able to see that because this is on sound only. So through our cases work and in general, tinnitus is something that can be really tricky to manage. And I'm hopeful that today, between us, we can demystify a couple of the commonly encountered questions we receive, and also clarify a little more of what we need to be doing and discussing prior to more specialised involvement. So to our first question, one, to scan or not to scan? Basically, do we scan everyone, or do we only scan those with unilateral symptoms? And would you advise that we do this prior to a referral to ENT?
Firstly, Alice, I really like your headsets, which you just alluded to with the mood lighting. They are phenomenal for relaxation and stress relief, which we'll come to later in tinnitus. But to scan or not to scan, I won't go to the cliche is the question, but I think we tend to have a much lower threshold for scanning compared to others. And we tend to scan almost all younger patients with unilateral tinnitus of recent onset with any other audiological symptoms. And also, I'll come to the descriptors for tinnitus in a second, but we also scan patients with pulsatile tinnitus, or any other otoneurological symptoms like unilateral hearing loss, headaches, disequilibrium, and the like.
So we alluded to the pulsatile tinnitus, a lot of patients want to know why this happens. And the question that we get quite often from GPs is, do we scan? Because obviously there is longevity and slightly different protocols with scanning to look at different elements of vascularity and things. So would you suggest in the situation of pulsatile tinnitus in the community, we facilitate a baseline scan, or especially if it's unilateral, or do we just leave it for the more specialized scanners once they've been seen in clinic?
So I think the first important task, whether in primary care or in secondary care, would be to establish the nature of the tinnitus. And as we all know, it can be either a continuous noise, hum, buzz, whistle, ringing, etc., or a rhythmic noise, which could be pulsatile or a clicking type of sound. So when patients come and present this tinnitus as a symptom, they don't clearly explain what type of tinnitus they have. They will say, they've got this ringing in my ears or this noise in my ears, and they're dreading the label of tinnitus, and they kind of say, this is not tinnitus. And when you say this is tinnitus, they say, oh, that's only ringing in the ear. So establishing that is the first step towards the investigation route, so in the management. And then whether, if it's continuous, then, onset, duration, relieving factors, the precipitating cause of this, whether it was, or various causes can be discussed, like age-related hearing loss, Meniere's disease, ototoxicity, other otological conditions need to be established, because if it's associated with an otological condition, you're much more relieved because you're not really worried about any other major pathology. That's so you can park that. Now let's think of pulsatile or rhythmic tinnitus. So it's important to delineate pulse synchronous rhythmic tinnitus versus clicking type of tinnitus, which can be spasmodic, which we can discuss later, like muscle twitches, etc. So if they say it's pulsatile, it's important to check with them, is it synchronous with your heartbeat or with your pulse? And because they sometimes will say it sounds like whether it's just a hissing or whether it's pulse synchronous is very important. Then you can start thinking of investigation. So to answer your question, it's a slightly convoluted way of answering your very simple question. Um, the thing is, you don't want to waste resources and unduly if it needs to be repeated or if it has got to be topped up with some other investigation. So to my mind, from primary care, if you just ordered a simple MRI scan of the brain and IAM, or internal auditory meatus, or the cerebellopontine angle, whichever way you requested, they'll do that protocol. Then you've covered most of it. If they say it arises a bit below from the neck, then you can cover the neck, but you're not going to get much more. But by that, you've excluded intracranial vascular tumors, uh, tumors in the internal auditory meatus, cerebellopontine angle. So a large chunk of your exclusion's done. Now you might be left with some patients who have a carotid bruit or a jugulus venous hum, or a pulsatile tinnitus arising from the sigmoid sinus which runs through the mastoid. And you could then leave them to be investigated with a vascular MRI, which in our case would be MR angiogram, either angio or a venogram. Very rarely would we go for a carotid angiogram. We would usually go for a MRA, MRV, or an carotid Doppler duplex ultrasound. Does that answer your question?
Yeah. So I think in essence, really, we're staying simple in the community, and the more specialised scans is what secondary care is for. And basically, we can rule out some straightforward and quite serious pathologies with a basic scan. if we feel that's appropriate. I think
Yeah.
that's a key thing, because we do get that quite a lot with patients that have almost inverted commas pulsatile tinnitus, but that needs to be a bit more clearly delineated by secondary care. And there are some things we can do preemptively, but that's almost whilst we're waiting for ENT and further involvement down the line.
Yeah.
So that's fantastic. So I mentioned earlier with regards to some perception in music, occasionally we see in patients that are hearing very specific musical tinnitus. I've had a Welsh all-male voice choir, a female opera singer. How would you approach this, or advise we approach this? Is there any slight difference that we need to explore? Any other alternative caveats or investigations that may be justified in this cohort of patients rather than the more classic, shall we say, tinnitus, which is that indescriptive sound?
So the patients who have a bit of musical tinnitus are actually quite articulate about what they're hearing. They will either say they hear specific bars of music, or they hear either choir music or Christmas carols or childhood rhymes and things like that, which can sound quite amusing, but it is incredibly distressing for them, because they can't get rid of that from their head. And a classic one was, I had a patient who kept hearing "Go Compare" music, and I could only imagine the vision of this guy with this long sort of dash, and it was a nightmare for him, and he could not get rid of it. So the thing is, a light bit of musical tinnitus, sometimes unclear bars of music, which may be linked to distant memory or not at all, aren't uncommon. And that's because the deeper hearing pathways link with centers of emotion, particularly the amygdala, which carries a fair bit of emotional memory. Um, but the other most sinister linkage with musical tinnitus, it's also linked with mild cognitive decline and also early dementia. So one needs to be cognizant of that. We don't routinely offer any dementia screening, but we do already have a research project where we are looking at unrehabilitated hearing loss with MCI or mild cognitive impairment. And we've got another project looking on the other side of it. We're looking through dementia services in the community, looking at how many have unrehabilitated hearing loss. And we've published on this. It's a very topical thing. And I can see the day when with patients with musical tinnitus will be offered or may be offered cognitive screening. But it is quite an emotive topic to broach, and not expected by many patients at the moment. But it is important. And also for musical tinnitus, it's also important for any intrusive tinnitus, which is hugely disturbing, in the appropriate cases where the patients are significantly distressed or depressed might be worth just probing any suicidal ideation, because that would require crisis management on the day.
Yeah. I think also that from a community perspective in general practice, we obviously would begin to explore their cognition if there's been a decline in memory, and look at more at the collateral um, stresses for them as well. So I think from a general practice perspective, we can obviously facilitate the dementia screening a lot better than in ENT. So I would expect that most doctors would be doing those concurrently before necessarily referring directly to ENT. Those kind of things would be considered at that time. I think it's just a key note that not all tinnitus is what you would expect, the classic sort of single pitch frequency noise, that if there is that little bit of something or suspicion of something else, you need to be looking more holistically and considering other options. So that would fall into your usual sort of cognitive assessment screening.
Absolutely.
And the main thing we have is that obviously tinnitus falls under the ear, nose, and throat umbrella, and inherently ear, nose, and throat is a surgical specialty. So how has that happened? Is it, what's the relationship, and ultimately, is there an operation that we would or could do that could cure it?
There isn't one, unfortunately, and that's what many patients come expecting, a pill or a surgery. Interestingly, you've touched on this topic about ENT, which is a very common misconception, and you having being linked to us will be very aware of it. And many primary care physicians are aware of it. 60 to 70% of our work is non-surgical. However, the 30% is complex surgery, but ranges from grommets and tonsils to complex ear surgery, skull-base surgery, hugely expensive auditory implants, anterior skull base and rhinology, and major head and neck resections and reconstructions. But in the non-surgical side, if you look at, for purely my interest, otology, you got hearing, you got balance, complex hearing losses, tinnitus, falls, and other autoimmune related conditions where we link up with rheumatology and neurology. In the rhinology sector, you can look at allergies, nasal polyps, etc. In the throat area, sore throats, and voice problems and swallowing disorders. So huge amount of linkages. There are about 27 linkages across specialty working that in NIHR, where I'm a specialty lead, we've looked at, and cross-specialty potential, cross-specialty working.
Again, I think it's just really helpful sometimes when we're sort of referring patients into secondary care through cases or directly is the real form of understanding and emphasis to patients that the solution to the problem isn't always necessarily going to be an interventional surgery. So that will automatically help with the patient level of expectation when they go into a doctor in secondary care. And I think we can really help communicate that effectively in primary care to just make sure that there's not this sort of heralded hope of a sort of an ultimate answer with surgical intervention, because that isn't always necessarily the best way forward or appropriate for the particular pathology the patient is suffering with. Is there anything that we can do to assist with guidance and expectation setting to patients before they get to ENT? Obviously, within the limitations we have with time parameters for appointments and things, what can we do that how can we encourage patients perhaps to accept the tinnitus pathology prior to their review? Is there anything that we can do to avoid or prevent any declination in their mental health and things anywhere that you would recommend that we seek some advice or just, signpost patients towards?
Yeah, quite a few things. And again, the time constraints in primary care, I'm all too aware of it. I'm married to a GP, and she would have seen 40 patients at 10-minute intervals like you do, whereas I would sometimes have the luxury of half an hour per patient. So I can see the very pressurized existence that primary care physicians are under. And I hear that through my involvement with cases over the years. So there's loads you can do. And in fact, I think it is very crucial that primary care deals with that in the initial instance so that it doesn't become an established condition. And we know from our research that early onset tinnitus, if it's dealt with early doors, can be suppressed, dealt and calmed down within an year or so with the patient engaging in self-help. So the key things: empathy during the history taking. Absolutely important, because they may have spoken to 5, 6 different people, may have spoken to your colleague in primary care who may not have had any interest. Many ENT colleagues don't have any interest in tinnitus. So the patients are already coming expecting not to be given airtime. So let them explain what they have and have empathy on that. The key phrase not to use is "there is no cure with it." And the other one not to use is "you'll have to live with it." So the patients sometimes walk into clinic and say, "I know there's no cure. Are you going to tell me I've got to live with it?" So I turn it on its head and say, well, there is some truth in what you've been told, because there isn't a cure for many things, and we live with it, but we managed it and controlled it very well and live fulfilling lives, like blood pressure, blood sugar, many conditions, your aches and pains, backache, etc. There's not a surgery or a pill that you have. You have therapy, you have lifestyle measures, you have exercises. And then immediately they start to engage. So I think that phraseology, British Tinnitus Association and we in partnership with them have looked into this phraseology a lot, and we've published as well. So firstly, those two things. Second step is when they say, you you've asked your screening questions, you looked for any neurology, you looked for any otological symptoms, then any other systemic ones, aneurysms, atherosclerosis, etc., thyrotoxicosis, or Paget's odd ones, which will increase vascularity. But then you've come to now explaining to them in your next 5 minutes. It's already sixth minute running, and you're 5 patients behind. So the thing to say is, I I promise you, it will get better, but you've got to engage with it. It's a lot of your time investment is required. Signpost them to the NICE and CKS. CKS has gone into NICE, I think, now, and maybe cases kind of self-help sites. British Tinnitus Association has got self-help leaflets as well, and explaining to them what you said in the very beginning of this discussion. It's a sound which is originating from inside your ears, fooling the brain into believing there's a sound whilst there isn't one outside. But you're not really imagining it. It's like a twitch anywhere else in your body. There are two ways you can deal with it: either flooding the system with an external sound so you don't really have the capacity for this to go up, and also the flooded the sound that is external will distract your brain into focusing onto it than listening into your head. And I usually use some sort of phone in analogy. I say something like, oh, I don't know, strictly say, lines are open, everybody calls in, nobody gets through. So it's like you flood the system with calls, and then the ear doesn't want to listen to the tinnitus because it doesn't have any meaning. And there are plenty of apps like Sounds of the Rain, Breeze, Dawn Chorus. But fitting that into the 10 minutes of your consultation requires rehearsal and practice. If you keep a spiel prepared, then tinnitus is a walk in the park.
Hmm. I'd second that, because we all have our own ways of discussing that with patients, and apps and things, and now there's lots of them that have automatic timers on that will turn themselves off. So if you're co-sleeping with a partner, then it's not going to interfere with their sleep. And actually, through the use of the apps, you both get a better night's sleep because you're more settled and you're in a deeper state of sleep. Um, so I think once you know a little bit more and get a bit more of an understanding about the process and the actual pathology, you do get into a certain pattern of describing it, and patients will be on board with that. So that's really great. Um, would there be any medications or maybe alternative therapies or non-medical options or even medications that you might suggest that could help a little bit with management?
So there is evidence that things like SSRIs or sedatives or anxiolytics in other form do not work. In fact, they might exacerbate the tinnitus. So I was going to say it when I forgot when we were talking about musical tinnitus. The temptation would be to give them an antidepressant because it is really triggering very depressive thoughts and issues. I think they are better served with some sort of therapy-based interaction, whether in the community or through the secondary care. Otherwise, they'll have the SSRI, benzodiazepines, etc., and then their symptoms will still stay, and they'll be even in a worse place because the medications have failed. The other important thing is also tinnitus patients also have a feature called somatization because the ear doesn't know where to place the symptom. So it'll place it somewhere in the head. So they will say, I feel a pressure sensation. The ear feels like it's going to burst. What's wrong with my ear? And the temptation is again to consider it as an eustachian tube dysfunction and give them a spray. Doesn't work, causes more problems with their nose, they get upset. So sprays or beta histine as well is used often because they sometimes get, bit of otological symptoms with that. None of these medications are of any use. I think a clear empathy, clear explanation, a non-medical route, encouraging self-help, and then a bit of therapy-based service if it can be accessed, and if you're desperate and the patient prefers, sent to secondary care. We are not, we kind of say, oh, we don't want to see, we are inundated, but we have capacity and we really need to be offering it to the ones who are struggling. And we need to offer it sooner rather than later, because later you can do nothing. After 3-4 years, it's in the deeper centers of the brain. It's got a huge emotional quotient. You're unlikely to get rid of it easily.
Mm. In terms of, and this is a bit of a curveball that I hadn't got on my list of questions, but I'm sorry to catch you a bit off guard. With regards to some of the medications, some people do microdose the amitriptyline for sleep facilitation at night. So usually 5 to 10, maybe 20 milligrams. That's obviously nothing to do with the tinnitus. That is purely from a more sort of sedating perspective and sleep facilitation. As long as that's explained clearly, is that, would you say that would be okay to try? Obviously, a lot of the patients that we see with tinnitus have got other collateral life stresses, circumstances where they have mood elements contributing to exacerbation of the tinnitus. So in the microdose that it's being used at, if that facilitates better sleep and they're more rested, less fatigued, that sort of suppresses a level of their sort of heightened emotional state. Would that be, it's obviously an off-license usage of that medication, would that be something that we could try if it works or helps, at least from a perspective of, like I say, the sleep? Is that something that we could use?
I think absolutely. I have nothing against that. And I think if it's been started, I never stop it. And my colleagues wouldn't either. The key is to explain to them, this is not going to cure your tinnitus. This is going to help you help yourself deal with the tinnitus, i.e., lack of rest makes tinnitus worse. So we are helping you have a refreshing night's sleep. If you have a stressy situation, this will get rid of the stress to some extent. And we use it for multiple other things: visual vertigo, atypical facial pain. And we clarify it for the patient as well, because sometimes they would say, but that's an antidepressant, I'll get dependent. They have these reservations or also dogmas. And I say, we're using it at such a low dose and it can be tapered off quite straightforwardly. Whereas if it were using 200, 100 or
Mm,
something like that, it's a very different ballgame. And then they will sort of engage with it.
perfect. And I guess the million-dollar multi-box question that we all want to know the answer to is there a cure?
Well, I would be a multimillionaire if there was, because I'll tell you, and you
I
may
can see you on
know.
your yacht there having a sip of fizz.
Exactly. So yeah, I can see the med in the distance. So we've been involved in multi-million dollar research. You may recall we had been part of the uh, trials which were American funded. Initially, it was $40 million, and then there was a 38 million euros linked injection trials. I had my own trial here, which had the medication with the tinnitus. Um, None of them gave us any um, more exciting results than the placebo, which was incredibly frustrating. In fact, the switchboard was jammed with calls when we ran those projects, and I still get people
Mm,
coming and saying, "Are you still running it? I want to register." That is how desperate patients are. But at the
yeah.
moment, there is no, and there are, I must warn you, there are a lot of outfits there who offer sound therapy, this, that, and the other, tinnitus, you know, cancellation, electron beam, and all sorts for thousands of pounds. The benefit from them is yet to be realized, apart from the fact that the patient would part with several thousands of pounds.
Yeah. So I think that was really helpful. Thank you very much for that. I think in summary, we know that silence is no longer your friend. We would aim to habituate patients and distract them and focus really on mindful strategies that, whilst they can be challenging for patients to initially engage with, can be ultimately invaluable, because there is very little longevity in the medicinal and any kind of surgical, or there is no surgical intervention that we can make. That sleep is vitally important to try and prioritize, and the collateral mental health surrounding the stress that can be induced with tinnitus is very important. Here ends our first lesson. Firstly, immense thanks once again to Cofre for today's session. And most likely, thank you very much for tuning in and joining us. We really hope you found this useful. Looking forward to hearing some of your feedback and anything else you might like to hear about as part of our potential series. We have a couple of ideas in mind, but as ever, we're at your discretion with topics that might be useful to cover. So please do let us know. Looking forward to doing another top tips with my exciting flashing headphones more than anything. Take care and travel safe, everybody. And thank you very much again, once again, to Cooperate.
Thank you very much, Alice.